Well, it is 4:30, and I know everybody usually hops on like within the next 1 or 2 minutes. So for time's sake, we'll just go ahead and get started. I think probably most people know you from the nephrology consult service, but this is Dr. Jain. He's won 1,000 teaching awards for the hospital. So we're really lucky to have you come and talk about the transition in nephrology wards and share your expertise with us. So we'll let you get started.
All righty. All right. So I'm going to try and keep the talk very simple. I think the intent of the talk really was to help you all understand what's happening starting late June in terms of renal wards. How do we plan to make the transition easy for you, easy for the patients, and make sure we're still doing a great job with patient care. I think being an academic organization, we also wanted to make sure that this did not take away the learning experience from both the internal medicine trainees and the nephrology fellows. So a lot of thought went into restructuring the services, and we're still under talks. So if you all have opinions, please let us know, online or offline. I think the objectives specifically here are timely care to patients with kidney disease, a collaborative care model, timely discharge planning, which often remains a challenge with this group of patients. And then I'll just, I think many of you have trained at UAB or other places. There's some nuances to patients on dialysis or advanced kidney disease that every organization does things differently. So my hope was to kind of let you know what's our easiest way of doing it at UAB and who to go to if you're having challenges. All right, so the restructure, and some of these colors are probably going to be redone about 3 different times. I've had the fellows and the residents and everybody giving input. But essentially what we did was the acute consult team, as you all knew it in the past, which used to take care of all the medical ICUs and the acute consults, whether they were any acute consult in Spain, Wallace would go to them. And what we did after hearing from the hospitalist group in terms of trying to have a more streamlined service for you was that we took away the hospitalist patients from the acutes team. And then the yellow team, which is a new service that we created, which will have 1 fellow and 2 internal medicine residents, will take care of all the hospitalist patients in the hospital who are not in the ICU. So that includes end-stage kidney disease, AKI, whatnot, glomerular disease. There's only 1 service that you have to consult if you all have a patient with kidney problems, and that would be the yellow team. This service would also cover Women's and Infant Center. So if your patients are there, they'll take care of them as well. And then any consults in the emergency room or triage. And this is important for you all to know. So if you have a patient in the emergency room that you get called about, and you think, well, this patient doesn't really need an admission, they just need dialysis, this is your go-to person. The fellow on that service is your go-to person. Or if you see the patient in the emergency room and you think they need to be seen by the nephrology fellow now, that's the fellow to call. So primarily what used to be the on-call fellow during the daytime is now the yellow team fellow. And then the red team, which is the chronic service, which is our nurse practitioner service that used to provide care to end-stage kidney disease patients who were admitted to your service, will no more take care of those dialysis patients because they'll go to the yellow service. And then we have a North Pavilion service, which takes care of the surgical ICUs and any consults in the North Pavilion, right? From what I understand, none of you have patients over there, or maybe occasionally you do in the non-surgical floors.
So we do occasionally have patients there. Yeah. Try to avoid that in general, but on occasion. But if this is the structure we go with, we can make sure we have education out to our group.
I think so. And some of these things, Tim, we can take as they come. I mean, I think if there's only 1 or 2 odd patients a month, I think we can keep them with the yellow service. If we realize that the number is higher, we might have to go to a point where we say, well, it's just easier. And I think from the perspective of continuity of care, making those relationships with the hospitalist team would probably help to keep them on the same team. So I'll communicate that to our services. All right, so any questions on that so far? I'm sure there's a million questions, but if there's some that I can easily answer, I'm happy to. Okay, I like it. No questions. All right, so cheat sheet. And I think part of this is just because now I think a lot of the things that we used to do as the admitting service and nephrology wards is probably going to come to you. And you all are welcome to ask for help from the nephrology teams, but sometimes it just helps to kind of get the basics right. So I think there's this concept of renal diet. So most acute kidney injury does not need a renal diet, just so you all know. I mean, I think all you need to do is put them on a low potassium diet. And even that is only if they're really not making much urine. If they're making urine, they typically tend to do okay with their potassium. Anybody with advanced CKD or end-stage kidney disease, they have to be on a low K diet, like a 2-gram, 50 milliequivalents diet. Low protein diet for CKD and end-stage kidney disease. I think usually when I started training, we used to say there's no benefit of low protein diet in chronic kidney disease. And I will say there's decent evidence in the last 5 years now that a lower protein diet can actually delay the progression of CKD. So again, not something that's going to make or break a patient's hospital stay. So from my perspective, at least I tell my trainees, as long as they're on a low K diet and a low phosphorus diet, I'm okay with everything else. I think it is important. A lot of these patients who are going to be admitted to you are very malnourished. They have ulcers, they're not eating well. And in all transparency, I will liberalize their diet and I let them eat whatever they want. I mean, I'll actually tell them, you can have ice cream, you can have sodas, whatever makes you feel better, and start to eat again. And if you notice patients who are hypophosphatemic, that is one of the easiest ways to get their phosphorus up. You can, you just liberalize the dairy and the ice cream in their diet and they quickly turn around. The other big one on renal wards and even on consult services, so erythropoietin stimulating agents, I would say that 99% of the times the nephrology team should be dosing this. But if you see patients who have end-stage kidney disease admitted to your service, please just keep it on your radar and on the nephrology team's radar. If we don't put them on darbepoetin or epogen, they will become increasingly anemic. Most end-stage kidney disease patients become more refractory to ESAs during hospitalization, whether it's infection or ulcers or malnutrition, osteomyelitis. All these will make them refractory to erythropoietin stimulating agents. So they actually need higher doses consistently in the hospital. There is no proven role for those in acute kidney injury, so we don't use them. Again, just something to keep on your radar. Blood transfusions, this is probably a little more nuanced, but I think if you see younger people who you think are going to be great candidates for transplants, we really try and avoid transfusions in them, even up to hemoglobins of 6.7, 6.8, 6.9. We kind of put them on a very high dose of darbepoetin, IV iron, and they tend to turn around. So unless they're going for a surgical procedure or there's a cardiac concern, I would recommend that we avoid blood transfusions as much as possible. If they do absolutely need blood transfusions, so let's say a patient comes to the emergency room for, I don't know, a skin rash, and they say, well, he looks great, the skin rash is nothing to worry about, but the hemoglobin 6.5, so we're going to need to admit him. That's an easy bedded out patient. They can do the type and screen in the emergency room. This patient can be dialyzed as a bedded out patient, get 2 units of blood on dialysis in 30 minutes and be out of there without ever needing an admission. So this would be the kind of a patient where you would call the yellow team renal fellow and say, hey, we don't think the patient needs to be admitted. Can you arrange for outpatient dialysis and a blood transfusion? And they should be able to help you out. All right. Bone mineral disease management. I think we spend a lot of time on this in the hospital. The three important things that I would recommend would be helpful is let's make sure that the nurses on the floors know that their binders need to be given with the meals. They can take them just before eating, in between the meal, or right after the meal. But if they take them their binders an hour before the meal or an hour after the meal, they're very ineffective. So I think when you order the binders, just please order them with meals. If the patients are hypocalcemic, they need calcium on empty stomach. So when the calcium carbonate is written for empty stomach and the nurse accidentally gives it with the meals, they will actually not absorb much of that calcium. So I think that would be another thing to think about. And then the last, which probably not something that the hospitalist team would do is, I don't make dramatic changes to their bone mineral disease management in the hospital. They have a full-time dietitian who sees them once a week in the outpatient dialysis units. And they've seen them for years and years. So trying to change these medications in the hospital can often be detrimental. A lot of times they're not on that medication because their insurance doesn't pay for it, or, because they didn't tolerate it well in the past. So we see this when patients come home from the hospital with changed medications and often have to go back to the same medication again. All right, so antibiotics, this is something that you all see a lot. We can give vancomycin, ceftazidime, cefazolin, and gentamicin in the dialysis units 3 times a week. Gentamicin can sometimes be harder to find, so it's always a good idea to ask the renal fellow to check on it. But we can administer these medications for 2 weeks, 4 weeks, 6 weeks, whatever is required for the patient's infection. The dosing is reasonably standardized, and over the years, we've adjusted the dosing in discussions with pharmacy. PD patients are more tricky with the caveat that, the infectious disease doctors, after years and years, are now on board with the hemodialysis antibiotic protocol. I think the intraperitoneal still makes them a little nervous, but there is good data to suggest that you could actually treat infective endocarditis, osteomyelitis, even bacteremia with intraperitoneal antibiotics with great systemic concentrations of the medications. And that avoids these patients from getting a PICC line, which we really do not like for these patients to get. Again, an easy discussion with the physicians who take care of PD patients. You can talk to the attending on the nephrology service, or you're welcome to page me or Eric Wallace, and we can help you out with arranging these without any problems. Home hemodialysis patients is a very small cohort, and it's a little harder to arrange the antibiotics for them, but not impossible. Again, you can call me and I can help you with that. PICC lines, I think you all already know, we like to avoid them in both PD and hemodialysis patients. The challenge being, I think, just every vein that they have is something that we could potentially use later for access. So we like to preserve their veins, and you all have admitted our patients who have, transhepatic, transvertebral catheters, and we're trying to do the best in terms of trying to avoid PICC lines. So I think anytime a question of a PICC line comes up in ESKD, the question should be, how can we give it to them with dialysis instead of having to put in another PICC line? All right. Volume management. I think you will see a lot of our patients who come to the hospital because they're short of breath, they're volume overloaded, they're edematous. I think the only time they should actually stay in the hospital for this should be if they're hypoxemic to the point of requiring oxygen. If not, they can be easily managed as an outpatient. This is exactly what outpatient dialysis units are for. They can be dialyzed every day in the outpatient unit if the patient agrees to it. And if the patient does not agree to it as an outpatient, then all we do in patient is try and make ourselves feel better. We get them euvolemic and they go out and they go right back to their volume status. So I would encourage you all to think about volume management as more of an outpatient process than inpatient process, unless of course they're hypoxemic and require that. One of the common things that comes up at UAB is cardiology comes by and says, oh, we're only going to do a cardiac cath on them once they're euvolemic. If they don't think that the cardiac cath is urgent, they can be made euvolemic as an outpatient and then come back and get an outpatient cardiac cath. Again, based on your clinical judgment, but there is the ability to do this very easily in the outpatient setting. if you think that there are patients who have advanced heart failure and they're truly watching their volume and still getting in trouble with low blood pressures, can't pull fluid, think of nocturnal dialysis. These are longer sessions, 6 to 8 hour sessions, helps us pull fluid in a slow fashion without dropping these patients' blood pressures, and they really tolerate it very well. Home hemodialysis is another modality that works well for this. So just, be thinking about these things when you're taking care of these patients and talking with the nephrology team. Right. Other questions that often come up, contrast. So if a patient is on hemodialysis and is anuric, not making any urine, the CT contrast is fine, is not going to affect them. If they are on hemodialysis or peritoneal dialysis and still make quite a bit of urine, which tells you that they still have residual renal function, we try and avoid CT contrast. Now, this is not true if they need an urgent cardiac cath or if there's a significant concern for a PE. So I think if it's avoidable, it's great to avoid it. It helps preserve their residual renal function. Phenomenal data that's directly related to survival and other outcomes in dialysis patients. If you can't, you can't. MRI contrast is safe. I've got an asterisk there because this was, when I was doing my fellowship at UAB, that's when we were just getting to know the effects of gadolinium in patients with advanced kidney disease. And we actually saw a lot of nephrogenic systemic fibrosis at that time. In the last 8 years, with the new gadolinium that they have, it just does not cause it. So there is actually now no requirement to screen for kidney function for MRI. End-stage kidney disease patients can have MRIs with contrast without any issues. And there is no good evidence to say that you should do dialysis after either iodinated contrast or gadolinium contrast. Sometimes you'll get a call, but there's just no evidence. If they get an MRI on Tuesday night and the dialysis on Wednesday morning, sure, but we don't change the dialysis schedule just because they got an MRI. All right. Access-related issues, if they have a clotted fistula or a graft and they come to the ER, we have reserved slots with interventional radiology where this can be taken care of as an outpatient next morning. So they don't need to be admitted for just a clotted access. They can come back next morning and get it declotted. Unless they're potassium 7 or there's an emergent indication to dialyze them, these people should almost never be admitted to the hospital. And in all fairness, we educate them to not go to the ER in such a situation. They're just supposed to call the renal fellow on call, and the renal fellow can schedule them for interventional radiology next morning as an outpatient. This would probably even be true on Friday night or Saturday night. So I know this question will probably come up. Well, it's Friday. They haven't dialyzed since Wednesday. Can they wait till Monday? And the answer is, we're doing this routinely for 90% of our patients. So if patient dialyzed on Wednesday, comes in on Friday morning and we find that access clotted, we arrange for an outpatient declot on Monday. We tell the patient to watch their volume status, not drink too much, stay on a low potassium diet. You will probably have the benefit of having labs on them. So if their potassium's 4.8, 4.9, there's not much to worry about. If the potassium's 5.7 on a Friday night, you'll probably have to bring them in. So if they have a pseudoaneurysm or pain in the access, that's probably a transplant surgery question. A lot of times they'll come to the ER, look at them and say, there's nothing that needs to be done urgently for this, can be discharged home. So that should not automatically mean an admission for most of these patients. If the patients do start dialysis in the hospital, transplant surgery can actually put in AV grafts that are immediate use that can be started. We can start using them within 24 hours. So if there's a young patient who you think is going to need long-term dialysis, that would potentially be something to think about instead of just automatically thinking about a perm cath. And then, this happens sometimes at UAB where they say, well, it's Friday. Why don't we put in a VAS cath on Friday and then we'll put in a perm cath on Monday? That should be an absolute no-no. Like this recurrent vessel trauma, one catheter in, come out, put in another catheter, it's not worth it. All these patients have central vein stenosis. So if you think they're going to need dialysis for the next few weeks, they should straight away get a perm cath, and IR will do perm caths on Saturdays now. PD catheter placement can be done by interventional radiology if these patients have not had major abdominal surgeries in the past. If they've had major abdominal surgeries, so small bowel, large bowel, if they've just had a cholecystectomy, hysterectomy, or appendectomy, IR can still go ahead and do the PD catheters. The benefit being they don't need anesthesia for it. If they do need surgical catheter placement, there's two branches that really do it. I would say about 70% are done by transplant surgery, and then about 30% are done by Dr. Permar in GI surgery. So, if you call transplant surgery and say, oh, we don't have the surgeon who does these catheters, then we can consult Dr. Permar, or, whichever order you all prefer. If they come in with a PD catheter that's not working, I would say your first point of contact should be the renal fellow. I would say about, if they're coming from home and never told their PD nurse, about 80% of the times you can make the catheter work. If they've been seen by the PD nurse and it still didn't work, that oftentimes that means they will need a surgical referral. So the fellow can kind of help you navigate that path. All right. Hypertension and end-stage kidney disease is very similar to volume overload. It's often related to volume and often can be managed as an outpatient. So remember, these patients are seen by a nephrologist once a month, by a nurse practitioner 3 times a month, and then by a trained nurse and a dialysis tech 3 times a week. So there's a lot of oversight for these patients. So they really don't need to be admitted to the hospital for a blood pressure of 190/90, for example. Hypotension on dialysis, you will get a lot of dialysis patients who come to the ER because, they had a pre-syncopal episode on dialysis, briefly got better, but they still came to the ER to get checked out. I would say that 90% of these patients are sent home after we see them. Almost always can go home unless there's a concern for a seizure or there's a concern for a stroke, which often is not the case. So if it's the classic hypotension of dialysis, I would say most of the times they can go home from the emergency room. Access-related clots, this is touchy because you will probably need nephrology to say something about them, but I will tell you, of the 100 dialysis patients that we get ultrasounds on, because we're trying to find a vein for a fistula or a graft or something, we find clots in about 60 of those 100 patients. And in general nephrology, I would say not one of us anticoagulates them for these clots. These are just access-related clots. And the risks of anticoagulation just do not, they far outweigh the benefits, considering these patients have had multiple catheters placed in the past. All right, this is the big one, disposition and social issues. I think we are trying to streamline it. We're far from there yet. If the patient's a UAB nephrology patient, they will almost always be placed in a DaVita unit if they live in town. And that should, as per the process, should have a 24 to 48 hour turnaround. So if a referral is sent in by the social worker on Monday morning, you should have an answer before noon on Tuesday in terms of where the patient can go for dialysis. Now, this is not for patients who are in the ICU or look chronically sick or have ongoing medical issues. But if there's not unresolved issues, there should be a 24 to 48 hour turnaround time. If they're going out of town, so let's say Montgomery or Gadsden or somewhere, or Anniston, I strongly encourage you to call the attending nephrologist and say, hey, can you make a call for us? Because I promise you, if we call a nephrologist and we say, we've got a patient that we just started on dialysis, would you be willing to accept this patient? That's the kind of a call that a private nephrologist is waiting for all day long. They would quit what they're doing and take that call. But a lot of times that information just does not get to that nephrologist, and the attending nephrologist can happily do that for you all and expedite the disposition. All patients who are going to be put into a new dialysis unit are going to need a Hep B surface antigen and a rule out TB test, which often at UAB is a chest x-ray. So I would recommend, if you think that's the reason for admission, that should just automatically be a reflex to order these tests so that does not stop the process. And like I said, please call the attending on service. If they're going to a UAB unit, you're welcome to just call the medical director of the dialysis unit. It's all UAB nephrologists. They can quickly accept the patient and make things work for you. And then for PD and home hemo, you can call myself or Eric Wallace, and we can make the process seamless for you. I also do want to remind you that there is a full-time social worker in the dialysis unit. There's one social worker who sees them every week, who knows where they live, who knows who their family members are, what transportation company they use, if they've ever been evicted, if they've applied for assisted living. They're already working on all these things. So these requests should not, one, be a reason for admission, or two, mean that the patient needs to continue to stay in the hospital. So they say, I want to change my dialysis unit. I mean, it's just a very polite, sure, we let the social worker in your dialysis unit know, and she can arrange that for you. I want to change my transportation company. Social worker can help with that. I'm trying to find some help going from my dialysis unit to UAB for my chemotherapy, appointments. Social worker can help with that. That is not to say that we won't, but I just would not delay their discharge for these reasons. Like I said, there's a dietitian in the dialysis unit as well who provides them detailed education. So not a reason to keep them back in the hospital. Advanced CKD, I think my only request would be when we are discharging these patients, please just communicate with nephrology so that we can arrange a quick appointment for them at the time of discharge, either with CKD clinic or their primary nephrologist. If they're starting dialysis, we talked about the VAS cath and the perm cath issue. Think about, if you think they had advanced CKD, now starting dialysis, I would much rather them get a immediate use graft versus a perm cath. Now, I will tell you, of the 10 times that I ask for it, I only get it once maybe. So, as long as have realistic expectations. Please also remember that we do offer urgent peritoneal dialysis at UAB for advanced chronic kidney disease. So if these patients, we just give them a choice. We tell them these are the options available for you. We have a dialysis educator. So any such patient will actually be seen in person by a dialysis educator who will come down, sit down with them, tell them about hemodialysis, peritoneal dialysis, transplant, palliative care, and then based on that, they can decide what they want to do. So all this to say that our knee jerk should not be, needs dialysis, put in a perm cath, get them home. We can get them a PD catheter and get them home just as quickly with urgent PD. You all probably already know this. There is no benefit of early dialysis in patients with advanced CKD. So if they have mild uremic symptoms, but their electrolytes are okay and their volume status is okay, they can still see their nephrologist as an outpatient and transition to dialysis. No reason to start it inpatient. And then we talked about EPO and avoiding transfusions, because a lot of these are young people and we'd like for them to be able to get transplants and, live a better quality of life. You will probably see a lot of undocumented immigrants who come in with creatinines of 13s and 14s and 15s. And in all transparency, the word is spread around the state and outside of the state that UAB is one of those places which will dialyze these patients. So we do get patients sometimes who live 2 hours away and they show up to the emergency room because their local hospital told them to go to UAB in a sneaky way, not necessarily directly. And they're basically coming in to start dialysis. Again, we can offer them PD or hemodialysis. Placement is a bigger challenge for them. So we can't really offer them PD unless we know that we can place them in a unit. So I'm going to try and give you a background of this now that you're in the weeds with us. UAB is contracted with DaVita as our dialysis provider of choice. And we had a big negotiation with them, I think about 5 or 7 years ago. And we said, look, I think as part of this, we'd love for you to partner and help us out with some of these patients. So we have a deal with them where they'll dialyze, I think, 12 patients free of cost for us. But right now we have about 25 of them. So there is a plan B where we can actually make an exception where beyond those 12 patients, we can go to the social work department and say, would you rather have this patient come to the emergency room 3 times a week and then come to the dialysis unit and use up all those resources versus UAB just strikes a deal with DaVita and says, we'll pay you this amount of money. Can you put this patient in a dialysis unit? So believe it or not, we've been able to put almost 12, 13, 14 patients in outpatient dialysis units in this manner. It's complicated. So probably the easiest way to do it is if such a situation comes up, please email me and I can work on it with DaVita and with the social work department and see how we can work things out. They do need an access. So this would be the patient where, say like he does not have insurance. So this is the only time we can get him an access. So if they need a PD catheter or a perm cath or, an immediate use graft, this is not the patient where we can say, well, let's discharge you and see if we can get you followed up as an outpatient. We end up starting them on dialysis. And quite frankly, by the time they come to the hospital, they're all uremic. So, all right. Last biggest one, probably going to be one of your best friends if used well. I think for those of you who've rotated on renal wards, you probably know I would say, depending on who's on service, if we get 20 calls from the emergency room every day, we probably do bedded outpatient in about 5 of those 20 patients. So about a quarter of those patients. Perfect example would be volume overload. Now, this is not an observation admission. This is a bedded outpatient. So they get the ER calls you, they tell you he's not terribly hypoxemic, but he's a little short of breath when he walks, not requiring oxygen, but we saw him walk to the door and he was short of breath. His blood pressure is 190/90. He'll be okay, maybe needs to be admitted for dialysis. You call the nephrology fellow, they can put them on dialysis, pull 4 liters off, and then send them home after that with instructions to follow up as an outpatient. Uncontrolled hypertension, potassium of 6.3, 6.6, 7.2, I don't know, missed dialysis. We see a lot of non-cardiac chest pain. I fell down and the right side of my chest is hurting, but the ER is uncomfortable sending them home. They've already had 2 sets of troponin. So we will actually put them on the dialysis machine, get a 3rd set of troponin and send them home. So, because like medical legally, you can't be all that, but it is easily possible. Want to change my dialysis unit. Like I said, we dialyze them and we say, talk to your social worker. Somebody comes in with a chronic foot ulcer. It does not need an amputation. All they need is antibiotics. The ER feels they need IV antibiotics. We can do a bedded outpatient on them, and the renal fellow can arrange for outpatient IV antibiotics. Don't need to be admitted for that. Pneumonia, hemodynamically stable, no hypoxemia, immunocompromised, so they need IV antibiotics. We can arrange for that too. So there are opportunities where the patient will actually say, look, can I just go to my unit? It's 3 o'clock. I can get to my unit and start dialysis at 5 o'clock. And I think that's completely okay, because as you all know, we are not able to get them on the machine before that also. Like the average wait time at UAB from when the ER calls us to when they actually get on the machine in non-emergent cases is 3 to 6 hours. So a lot of times they'll actually get to the units sooner. That's all. That's all the quick things that I can think of off the top of my head.
I know when we've talked to the group before, I'm sad to hear that Shanus will be, it sounds like, staying with the other team. Everybody loves Shanus. So with the yellow team, I'm sure we're going to be satisfied, but everybody's going to miss Shanus.
Right.
I'm already going to protest. I think that was in our contract, Dr. Jain, that we got Shanus.
I think so. Didn't we renegotiate all the contracts?
What about, I have a question. With the ED, I imagine are they still supposed to call the renal fellow first? Just by the service going away, likely they'll call us first, or?
So I think what we've talked to the ER about is if you think that a patient needs emergent/urgent dialysis, the renal fellow should be the first call, akin to what they would do for a GI bleeder, for example. But if an ESKD patient comes in with stroke-like symptoms or pneumonia or belly pain or leg pain or a toe ulcer, then they would probably call you first. And if you find a reason for concern, or you say, well, we don't think he needs to be admitted, if they can just be dialyzed and sent home, can you check with the fellow? Then the fellow will help out.
Oh, sure. Yeah. And I mostly meant like these bedded outpatient ones. They
Right.
should be calling the fellow. Okay.
So for the chronic bedded outpatients, the ones who come to UAB as their dialysis unit because they don't have an outpatient unit, they will be calling us directly. I will admit, the ER does not ever think anybody is a bedded outpatient candidate. So they never call us and say, oh, could you just do bedded outpatient and send them home? They almost always actually fight it because they're saying, oh, we really think he needs to come into the hospital. Because why? Oh, because he needs dialysis. We can do dialysis and get them home after that. So no, we almost, I mean, I wish. I'm still waiting on that call from the ER saying, oh, I think he just needs bedded outpatient.
Okay.
Doesn't happen. Okay, seems like everybody knows what to do. I think we can. You
I
all
think this
have.
was great anticipatory guidance from you, Dr. Jain.
Yeah.
I have one question. In the setting where we're getting some resistance from interventional radiology about placing perm casts, and they're saying that they still want us to come and place a VAS cath, even though the turnaround to get a perm cath might be under 48 hours. How should we address that? Should we just reference this conversation, or do you have an opinion?
I just fuss. I just say I'm not going to do it. I mean, I'm not going to put in a VAS cath in somebody who doesn't need a VAS cath. I will say if you talk to the attending, it almost never happens. It's often the residents who are going to try and push this. And I think, we are happy to, this is actually a great point. I mean, I'm happy to reach out to well, it's not Dr. Caridi now. I think it's somebody else right now, but we can certainly reach out to them and request that this become the standard of care rather than people having to put up with resistance. So a little bit of push and pull.
I'm just wondering how we're gonna, as a service, I mean, this is all great stuff, but there's a lot of us. It was great, but I've already forgot a lot of it. Like, how are we gonna know what we don't know? There could be a quality cycle so we can learn.
Right. So I was actually thinking of maybe creating like a, I'm a big fan of one pagers. I can create like a one pager cheat sheet, laminate it,
It could be a good start.
Right. And then once we've honed down on the colors, I'll let you know. There was a request for pink as well. So good deal. You all have a hospital meeting to go to. I have a baseball game to go to. Everybody have a good night.
We'll let you know if there's follow-up questions. Thank you, Dr.
Yeah.
Jain.
Perfect. Good to see you all. Take care.
Bye.